I was just wondering about any essential oils or just maybe some soft scents in the room that might be, I mean, I know some patients, or some people don't like the scents, but,
Yeah, we have to be
lavender
particular
or
with that
something,
person.
so.
And it's actually something that we had considered, and we were thinking about proposing it forward, but there was concern about sensitivity to odors for the rest of the
Yeah, we could ask,
patients.
yeah.
Which is something that we're exploring.
Customize it.
Yeah, Dr. Madden was bringing it to some of the kind of committees and some of the administration to see if it could be actually, so I'm glad that you're asking for it too. That means that it's, warranted.
Yeah, I think that would help.
But maybe while you guys are,
I'm sorry.
Yeah, yeah,
Now,
yeah.
he mentioned in the video to call social services 24/7. Who do
You
we call?
can, I think
Oh,
the
yeah,
way,
there's always somebody on call.
you have to call who do you call, Janice, the house?
House supervisor for the night or after hours, like on weekends?
Yeah, who, Janice, do you know who, I think you call Cindy, who do you call for social work after hours?
We have the supervisor do it for us,
Okay,
and they get the person that's on call.
yeah,
So it's the person on call, not particularly
it
you.
wouldn't be
Oh,
us,
okay.
yeah.
Yeah.
I call myself,
I knew
I'd love to come, but,
Okay.
Now, do all, okay, no, I know the answer to this, no, they don't. But why do not physicians utilize palliative care a little bit more? I heard about an incident with a patient who passed away, and it was just really, not primary care, but her cardiologist was handling it, and it really was not a good situation.
a patient recently. You're saying,
Yes.
I mean, we ask that question ourselves very often. I mean, please feel free as the bedside nurses to bring it up to the physician. I know it can get sensitive and can get complicated, but it has to be, for our physician to get involved, it has to be a physician-to-physician consult. So technically, the non-physicians among us can get involved without a physician consult, but we even like to run it by the primary because we've had bad, out of respect, it's their patient, we want to, work as a team. But I would definitely suggest bringing it up to the physician. And maybe if multiple staff do, they'll be able
So
to consult.
so that would be the first step, and then, so
Yeah,
you don't just
unfortunately, it has
come
to
in,
be
you
a
don't look at the patients
Well,
that
we
are no
sometimes-
codes and say, oh, well, let's check in.
You're always welcome to call us to do a palliative review, they call it, which means, you can reach out to the non-physician staff and we can look at it. I mean, and then it depends. If it's a physician that we're used to working with, we would be fine to approach him and say, hey, is it okay if Dr. Madden or Dr. Busrak gets involved? If it's not a physician that's used to working with us, I mean, it may come better from the bedside staff. So it's something that we could work out, but you're always, always welcome to call us. And even Dr. Madden, even though he can't formally be consulted, if you want his help, he can be available to help navigate,
Just for clarity on that, I was under the impression that nurses on our own can put in an order for a palliative care consult. Is that not correct?
So technically you can. I mean, you can put in the order, but it has to, I mean, for our physician to be involved, it does have to be a physician consult. So I mean, I think when you put in the order, it's under a physician, right? So they would have to technically sign off on it, I believe, or it's...
And there really should be a physician
There's a choice that says order not requiring physician approval.
Yeah, so technically for our physician to be involved, it needs to come from a physician.
Ideally, the ordering physician should also have a discussion with one of our palliative care docs so that they both have an idea of, what the goals are and why the consult is being requested.
But if you,
So
if
is
you
that a
do...
yes or a no?
You can put it in, and we see that sometimes when nurses put it in, and we will address it, and we'll reach out to staff and check it out, and try to reach out to the physician and say, we noticed that one of the nurses put in this order, are you comfortable with our physician getting involved? But technically, our physician can't take a nurse's consult. They need a doctor-to-doctor consult to formally get involved.
But it's still a good idea to do it,
Yeah.
to come from the nurse.
But probably the best
If you
thing...
really think that somebody needs to have an intervention with palliative care, go right ahead and do that. That's within your scope. And you may not get Dr. Madden in the room that day, but you've started the ball rolling. And that's
You mean
really
entering the order?
important.
And even
Entering the
better...
order
As a non-physician order, because it's not going to Dr. Madden, it's just
Going
going
into
to
the-
palliative care team.
But
They'll
even
get the
better,
message.
if you are comfortable asking. I mean, sometimes if it's in the middle of the night, I mean, you're probably your night shift, because, so I don't know if you have access to the doctor's You don't need to like wake them up in the middle of the night for palliative care or order anything,
Just tell
but,
you, speaking for myself,
yeah.
I only do that in a situation where I am not comfortable.
Okay, then for sure, keep doing that, yeah. And we'll respond how we can, you know,
Thank you.
yeah.
Are you notified though of patients that are on no codes or, no, there's nothing, something that comes out on Epic that?
No.
So you
As far
can
as I
have-
know, there's no automatic flag that tells us when a patient switches from full code to no code. But if there is a palliative consult that's placed, we do see it in Epic.
Okay, but only if it's placed, okay.
Is it something we can do where, it's probably a doctor learning curve, but there was, I don't think palliative was involved in the case, and I think the patient is still in the hospital, but when the doctors, the oncologists get to the point where they realize, oh, there's not anything else we can do for your treatment, I don't know, just for composition of care, it just seems like it would be beneficial to have you guys there to, if you haven't been consulted before, to be present at that time. This person had a language barrier, and at the same time, they're left, somewhat disheartened. They were doing an MRI just to affirm it, but, it was
I did leave a message, I know what you're talking about, to the chief of the social worker to find somebody who can come and speak to the patient in their language. Or they can use language line, which probably at that point really is not effective because the patient's being told, this is it.
Yeah.
But I think that was yesterday that I took it, or the day before.
It would just be nice to have them know these guys, that way, they had somebody to hold on to, to guide them.
And I did say that she speaks fluent Spanish better than I do.
Yeah.
Beautiful Spanish she speaks, yeah.
It just was,
Yeah,
a little of rough moment for the patient, when they had to transition that way, and,
Yeah. And I mean, definitely, again, because of all the dynamics of how palliative has developed, and, I came about a year and a half ago, and, a bunch of us got kind of hired a year and a half ago, so things were changing. So in response to how things had been previously, we had to be a little careful about really running things by the primary and really being careful even for the non-MDs to get involved. But I mean, at this point, it is building, and I mean, if you guys really need, for sure, the psychosocial support, definitely don't hesitate to ask me and ask Karen, and even if we can't get Dr. Madden in, I think it would be a lot for an oncologist to say, no, I don't want the social worker to tell. Yeah, I mean, I think that still feel free to
because we didn't know the doctor was going to have that conversation with the patient, and so it's
It was
probably...
really sudden. I sent from, no, not Jan. I forgot her name.
Sarah?
No, not Sarah.
Sherry?
Sharon, sorry, yes, I forget her name, Sharon, because she does speak some Spanish. So she wanted, they were fine at that point, that she didn't need to do that, they were the mom and the patient.
But hey, if I speak Spanish, it's a good excuse to get, I mean, we get in everything we can for support, so. Yeah.
Using Jessica and Karen, they're very approachable. I use them a lot. I kind of just go over, hi, how you doing? Just giving you a heads up, there's this situation going on. I'm not, and they'll look at the patient, they're really responsive at looking at them, and they're respectful to the doctors, and they'll be like, okay, let's see who the doctor is, and I don't, for me, palliative is taking care of the patient from the beginning to the end, and that's what palliative should be. And we shouldn't have to wait last minute to introduce them to patients who really need it, because they're there to help them through this journey also. It's not just, not just the bedside nurse and wait for it to be to the point where we're all distressed about it, and the doctors are now like, okay, hands are up in the air. I think we need to also introduce that to the doctors, that they're there. They're not there at end of life. They're there through the whole time from the patient's time of diagnosis, whether they're going to be terminal or whether they're going to survive this. That's what palliative care is about. And that's where we need to encourage the doctors to use it. And we need to honestly educate them that it's not, they're not there for end of life. They're there to help along the way.
I think you should be like,
You're a champion.
we'll work together.
The other hospitals have a protocol where palliative care is involved as part of the team, it is. It's
Yeah.
just like nursing, you do math, palliative care, and dietary, everybody should be involved. That doesn't mean that it's the end of life, it just means it's comfort,
Yeah, we want to change the perception that it's not the very end of life. I mean, I know this is particularly about comfort care, but we don't want it to only be comfort care, just like you guys are saying. And some of the doctors are using us like that, which is such an honor to be with patients early on. And when they're getting better, that's such a pleasure. They still have symptoms, they still need support, so,
How do you think the night shift might be able to utilize your services?
That's a very good question. I mean, because we obviously want to be available and supportive to the needs of the night
I'm
shift,
not
but
suggesting that you be on call.
one day, that's probably where things are going, but in the meantime,
well, I think it comes down to something like just as simple as communicating between the night shift and the day shift so that issues and concerns that are noticed on night shift are appropriately brought forward to day shift so that they can be brought forward to us while we're here. We're in the office Monday through Friday, basically 9 to 5. So,
What about them sending you an Outlook email?
absolutely.
Yes, for sure, Outlook emails. Also, there is a new Epic thing that came up in this latest update. It's a palliative care note. So if you, maybe we can try to have Tim or one of the CIS people send out to you guys how to access it, but you can actually write notes. So I mean, that's a communication, but Outlook is even maybe more private, so that might be better.
So that
Janice, you
goes
wanna
to
send out-
palliative care, those notes?
Well, it's just a note in the chart, but it's kind of like palliative care themed notes. So,
Oh, wow.
I mean, it's more of like a communication tool rather than a progress note area. It's like a screen.
So if a nurse wrote on a palliative care note, does that mean you automatically get notified that there was a palliative care note or written on a particular patient, even if you're not involved with that patient?
Well, no, I mean, I think it would be only the
not
patients
a
we're looking
trigger.
at, but we can have it wrenched into our system. So now on my screen, I always see it, even though we're not really using it yet, but it's just a constant on my screen. So that might be a little complicated, but Outlook for now, for sure,
Yeah.
would be a great way. Maybe Janice could send out our contact info, and that's probably a brilliant way.
I think you can also wrench into your Epic DNR patients. So whoever is DNR pops up.
Yeah, you can on your
Anything
list.
that you want to see is wrenches in. But I think I'm going to look for that.
For them?
Anybody can wrench in anything.
Yeah, but they could.
So they could get the
They could have
information kind of,
a dashboard, and one of the things on their dashboard would be DNR.
okay.
But let me ask you guys, I mean, what Dr. Madden was saying, is there anything that you all can think of that would make the comfort care process easier from us or just in general to bring to our attention?
I think part of the issue is doctors use different comfort care orders. It's not always Dr. Madden's initiating it, or, even Dr. Rusrock. Different ideas of what the comfort care is supposed to be. And I think a mindset for us older nurses, we're used to, right away, there's a drip going, They're at that point, they're ready for a drip. But I'm starting to learn that we're utilizing IV pushes and allowing this to happen and eventually transition to the drip. So I have to change my mindset, I know this patient's pain, I'm thinking, oh, okay, put them on a drip, but knowing that you guys are going to transition them eventually, that's helpful, but it's how the doctors use that comfort care. And when they open a screen, it's not like our protocol used to be, where check, 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 check. It's now, okay, I'm going to use this, I'm going to use this, I'm going to, so everyone's idea is a little different, and they don't know who to go to.
That's a good question. Yeah. Do you find that to be a struggle, knowing who to go to? Yeah.
And also, I've heard I really have not spent any time on the comfort care orders, but I've heard them complain about them for just hard to access, hard to work around, so maybe that keeps them away too a little bit.
Right. I mean, hopefully, sometimes if they want to just refer to palliative and have palliative manage the comfort care orders, I think that's often what happens once palliative's involved. Sometimes if the primary really wants to be involved with it, and Dr. Mann will work with them because he's a lot more comfortable with the comfort care orders just because he uses them more. But I would say as far as not knowing who to call, sometimes it's kind of a case by case. It gets confusing when pain management and palliative and the primary who's involved is all, are all involved. But I would say, don't hesitate to reach out to Dr. Madden for sure. And even if he's saying, I'm going to defer this to, the pain management or something because of all of the aspects of the situation, he'll still talk you through it. And, never, he really welcomes reaching out and clarifying with him,
I was wondering if palliative care should become part of regular process on admission. That you visit all the patients, talk to all the patients, what palliative care is, what that means. Educate. So next time, 10th time they got to the hospital, we already know, and we don't have to start from zero. Fighting it all. That's an idea.
palliative care wonderland.
Ideal. Let me tell you something, despite the fact of all the glitches that we have with any department and everything, it has really been a blessing to have you on board, and it's been a tremendous help to a lot of the staff to understand how to manage and treat our patients. It's made a big difference.
I loved collaborating with you all, and I think that, like Anna, what you were saying, you're right, it is a large uphill battle in many ways, but I would just say, we're all kind of in it together, and we're all learning. We're all pursuing it too, so all the little bits, if you all see something appropriate, you reach out to us, and we'll reach out to you, we try to be around as much as we can, and just, piece by piece and case by case at this point.
And I'm glad you're opening on the 4th floor.
Yes, right.
Perfect. Do not move.
We also just wanted to make you guys, especially on night shift, you might not be as familiar with some of the materials that we have. So I'm going to keep one of these, but maybe you want to just pass these around a little bit. And there's some extra booklets, actually. These are inside, but so you can see it. These are the comfort care folders that we give out when someone comes on to comfort care. So we just updated them relatively recently.
Jessica,
Yeah.
do they come in other languages?
Oh my dear, we just got them in English.
I'm going to say not yet.
Not yet.
That's what I say. Every single patient, no matter how sick or how healthy, should be getting information about palliative care should start at
Well, in the admin packs that folks on the oncology side get, and I don't know if we do it on our side or not, but there's that palliative care brochure that we put in every oncology admin packet.
That's great.
Do we use it? I don't think so. That one right there.
No.
We could though.
Packet, there's a few things. There's just a letter talking about kind of what is offered to them, staffing-wise, hospital-wise on comfort care. There's an article about how to be with a dying person, just kind of some guidance and support for that. There are, maybe some of them are missing it, but there should be, oh, here we go. There's a next of kin checklist, and usually, in most of them, there's also a list of mortuaries. For some reason, not in this one, but it's in most of them. And we are available, obviously, to talk them through maybe pros and cons. We're familiar with some of the, more frequently used mortuaries, because obviously it's a time where people can feel a little lost. And then here, like Dr. Madden was mentioning, the bereavement resources, there's some really excellent places. And we can also, just give them the list, we can talk it through with them and see which entities might be good for which families. And we actually also offer bereavement follow-up, and sometimes it's hard for them to come back to the hospital setting to take us up on it, but we've had a few that have wanted to meet one-on-one, and we definitely accommodate that.
I have one more question. Yes. You are social worker.
I am.
Who is supposed to talk to patients about advance directives? I know we usually ask at the admission, do you have advance directives? And then we are supposed to call social workers. So how diligent are social workers actually explaining?
Well, that's been one of the avenues, especially maybe 6 months ago, that when we were trying to figure out, brainstorm how to get palliative more involved, we were saying, well, why don't when we have consults for advanced directives, palliative will take that on.
Exactly.
So that's what we've been doing. So you can call me, and you can call Karen. When we see that case management order, we've kind of asked the case management staff to refer it to us, and they do. And sometimes when we're a little swamped, we have to kind of refer it back to them, but most of the time, we will take that on and speak in depth, and so that's one way to get us involved too.
I think Jen has worked with you with that, because sometimes I'll ask Jen, she'll say, palliative care is helping with the advance.
Yeah.
So they have good communication all the time with our social work Jen, and I know our case managers change frequently, but when we do rounds 3 times a week, Monday, Wednesday, and Friday, that's when it's very important for us as charge nurses and the nurses to be involved and let case management, social work, because they're there. What's going on? I go over Caritas.
Absolutely.
I also go over with the case managers and social work Caritas issues. So it's not just oncology, just we're over there on that side.
But you're right, Ruin, that's a perfect opportunity to bring the other team members in. So you're not managing all this on your own.
Because dietary's in there, typically they're in there, so if there's issues with food or that situation, they're there, pain. If we need to invite Dr. Kotler, we do that also, and she'll come in. And sometimes she just pops in and asks, are there any issues, like with some of our particular patients she's already working with. But that's where communication is important and passing it on to everybody involved.
Jessica, if a patient is newly diagnosed with cancer and does not have any advance directive upon admission, is it okay to enter your order and like as a social service consult for the advance directive?
Absolutely. It's a wonderful thing.
You don't need a doctor's order for that. It's social. It's like dietary. It's like just asking social work.
Just remember that we do have a regular social worker, and
Yes.
Jessica's dedicated mostly to palliative care. So the regular social worker will be looking into that as well.
Can I make a suggestion? When we charge check, many times it's, the nurses are putting no information given. Is it possible that we could make the extra step just to call a social worker and leave them a message and just let them know that, could you do a follow-up when you come in the next day for the advance directive on this patient? If we don't know the source of it, that would help, I think, catch a lot of that and get the conversation going with a lot of the patients that
Do
we
you have voice that we can leave messages?
Oh, yeah, the same number.
Okay.
Yeah.
Because I leave messages, voicemail messages for Jen
Oh, yeah.
or Jessica. So you could always leave that. Even night shift, you're available.
Or we could just put, if the patient, and then just ask them, would you be interested in it? And if they don't want it, then just put refuse, patient refused, and that closes the door, and we don't have to address it again. But then at least it doesn't leave the door half open. But then we'd have a definitive answer for the patient.
I have an issue with sometimes being able to approach family about death and dying. It's not that I haven't had the experience, but I think sometimes we have to be careful who we are approaching and the background. You can't just blurt it out to somebody. So you've got to take all that aspect, all that information into consideration, because some will just come out and be very angry. And doctors too. They're like, this is my patient, and I know there's particular doctors who like, do not discuss this, do not go there. And even though you feel in your heart that you should, I wouldn't put it upon yourself, honestly, to do that, because you're putting yourself in a very awkward position.
Perhaps not to bring it up.
Well, right.
If you're
but-
alone with a patient and the patient begins having that conversation,
That's fine.
yeah, I wouldn't shut it off.
Right,
because
but I
I'm afraid
don't,
of
there's
the
some
doctor.
that are like, feel like,
Yeah.
hey, you're dying and
Yeah.
there's a finesse to it. You
By
can't
the way,
just, just go out and say, what's your plan? You're not doing so well.
Which is why
I mean, you can be pushy with certain people.
Which is why it'd be great for palliative care to be able to get involved earlier, because that way we can get to know the family, we can get to know the patient, we can start to build a relationship with them. So that those conversations, while never easy, may be, a little bit more, they may be more open to having these conversations.
So is palliative care when the patients are in the hospital, now you only deal with them when they're in the hospital, and then say they do get a little bit better and they end up going home. I didn't look at the pamphlet, so are there resources in there for hospice, or do you follow up with them at home? or-
So you can see, our team is an inpatient
Oh,
team,
it's
but
inpatient.
we are kind of slightly in process of expanding, but nothing formal yet. But we definitely, one of the big conversations we have with families is about hospice, and if they're appropriate and they want it, we will set that up at the hospital and go through it all with them before they get discharged. There are some outpatient programs that we, if it's appropriate, they kind of have their own stipulations, but there are some outpatient.
Because you've developed this relationship with them.
Yeah.
And, it seems just to extend that a little bit further, I think just knowing that you're helping them get the same good care outside of the hospital.
We
Absolutely.
like to do at least a close handoff, even if it can't be yes,
Got it.
Yeah.
I think one thing on days that we get to see, unfortunately at night doesn't, is all the care that you guys provide. Not just what you normally do within that little umbrella, but we've had a couple patients, unfortunately, in room 2410 that, of other cultures, that they've been able to provide us with certain things or rituals that have to occur as the time draws near. And so if you can call them, Dr. Maddie can give you, oh, well, they shared this with me, let's do this. Or a nurse may download. Particularly, there was one case of Jewish culture, and there was, I think, 2 pages of what the nurse was supposed to do. And one of them was to put a towel over the face. And as we're going through that list, they were like, absolutely not. And it's like, that's okay, but at least we showed them that we valued their request and that we were going to meet them. And this is one that they did not want done, and we weren't going to do it. But there's a lot of specifics in certain cultures when the time does occur that we should know about and kind of adhere to for them as well. It's out of respect. So they've been really helpful with our patients. Unfortunately, in that room, we've had a lot on that side, but it's been helpful.
Right back at you and all of you. Just the incredible, for Caritas especially, I know that's what this whole symposium is about, but the type of support and care for those patients has really been above and beyond, and we've been pretty blown away by you guys. And when you're on, we are so relieved, and it's very much a team, just 100% team effort. And definitely always feel free to also just be open with us and ask us, and if there are any concerns or challenges, we and Dr. Matt and all of us really, really welcome input very much. So, just one more quick thing, just to make sure that also for night shift knows just this last piece of this, which is actually very helpful. I think it's a Providence booklet, which I think is really great, about what to expect end of life, the symptoms, physically what to expect, and just to normalize all of that, and just a little bit about bereavement. They can just read it at their leisure. It's a nice looking thing, which is always helpful. It's inside this folder. The folders are located every place, every unit in the filing area where it, all the comfort care, like the end of life, sections.
Sign-off sheets.
Yeah, so it should be in there. In addition, in the Epic downtime room, that's where I keep it in a big box, like a backup, one.
I know spiritual care does this, they have limited supply, but I don't know, getting extra little stereos or CD players or something that can set ambiance or just enjoyment for the patients.
We have one in my office. In our office, we have a CD player. People use that anymore.
We have more, because sometimes I
know once.
I know they disappear sometimes. So
we have one.
Okay.
Yes, we have one. It's in there. So
Who would we contact in after hours running meetings if you're not available, if we wanted to have a patient requesting that?
What, music?
The
Spiritual care.
Oh, we can just
We
get
can use the TV. TV also has
No, it
that.
doesn't.
Yeah, we had a patient who particularly didn't want the TV on.
Oh, really?
The family, they just wanted a CD.
Try to remind me, or Anthony, we'll just order a couple to the unit.
I mean, the music. We had a
CD
bunch of
player, right?
CDs.
Isn't that what you're talking about?
But we didn't get music though.
I think there's one in there.
Or maybe something that has an auxiliary cable that you can hook up. Maybe sometimes families may want to bring in like a loaded iPod or music player.
And they can use the iPhones for that.
Yeah,
they have that in
Oh, they have
the
that.
radios.
Yeah.
The computer's nice.
Can I just mention one thing since we're discussing comfort care also? Please don't forget that house supervisor can be called for No One Dies Alone. So for
Thank you
those
for
patients who
mentioning.
don't have families and you feel that this person just needs someone there, you can call them to have a volunteer come and stay with the patient during that time.
Not during
And
the- You don't
sometimes
feel
it-
so guilty about
Right,
not
and the
spending
family,
time.
exactly.
No,
And it
not
gives the
during the night.
family.
They're not available at
They
night.
have on-call ones now.
But just make sure that there's no family involved, because if
Right.
there's family involved, they will not send.
Yeah, I mean, it has to have some you have to have permission from some
But
families.
tonight they don't have any, you say, Helen?
No?
Not available till 9 o'clock.
Oh,
But I mean, I've heard talking to Erin and the volunteer people, if they really feel, if the individual decides they're comfortable staying, sometimes they will. But yeah, I know, it's not set up that way.
And Erin is the lead on that. But it is, she does say there's a fine line. You've got to ask permission from the family, if there's family involved, because some families get,
And feels invasive.
feel invaded.
Yeah.
I think if they're objecting to somebody being there, they'll come in themselves.
Any more questions? Thank you very much.
Thank you.